everyone, I'm Deep Parikh. Welcome to the Zeiss Ophthalmic Medical Education Summit. I'm Adjunct Assistant Professor of Retina and Uveitis at New York Eye and Ear Infirmary of Mount Sinai and Adjunct Assistant Professor at NYU Langone, Long Island School of Medicine. I'll be moderating today's session on retinal disease management from routine to extreme. Here joining me today is our esteemed faculty panel, Dr. Sarah Gleason and Dr. Carolyn Major. And I'll turn it over to Dr. Sarah Gleason to go ahead and introduce yourself.
Thanks, Dr. Parikh, for that introduction. So my name is Sarah Gleason, and I practice in New York City. I'm assistant clinical professor at SUNY College of Optometry, and my main areas of interest include glaucoma and retina. We'll be getting into a lot of retina today. So I'll pass it over to Dr. Major next.
Again, such a pleasure to be here and welcome everyone. I'm Dr. Carolyn Major. I'm an associate professor and the director of residency programs at the Oklahoma College of Optometry. And I do pretty much any sort of disease. My real forte, I think, is retinal disease, but glaucoma, neuro-ophthalmic disease, systemic disease, I love it all. A pleasure to be here today. Looking forward to this discussion.
So welcome again, everyone. I'm really looking forward talking to you about interesting retinal cases this evening. Specifically, I'm going to be talking about the role of OCT angiography in managing our diabetic cases. So both routine cases and extreme cases related to diabetic retinopathy. So we'll start off with the case presentation. We have a 61-year-old female presenting for a doctor-directed follow-up. Now she's managed in our clinic for both glaucoma suspicion and diabetic retinopathy, but we're going to be focusing just on her diabetic history and imaging today. So she has type 2 diabetes, a fasting blood sugar of 110, and an A1C of 8.5. She reports moderate control and that she's taking 2 medications, and her BCVA is 20/20 in both eyes. Her anterior segment exam was unremarkable, so we'll jump right ahead to her posterior segment imaging. So here we have her color fundus photos, and you guys can see here that she has some retinopathy going on. This wasn't the first time she presented with retinopathy, but it looked a little bit worse at this particular visit. So if you take a look, she does have some microaneurysms, most significantly temporal to the macula in both eyes. And she also has some retinal hemorrhages, evident superiorly, and some areas of exudation as well. So sometimes I like to do red-free photographs in these cases, especially if the retinopathy is a little more subtle or if the exposure wasn't just right on the color photos, because it really highlights those areas of hemorrhages even more and the areas of exudation as well. And you see that highlighted here in the red-free images. So we didn't perform OCT at this particular exam. We brought her back 3 months later to do so, and we have her MAC cube posted here. So as you guys can see, in that 3-month period, she actually developed some macular edema. So she has an area of retinal thickening superior to her macula in the right eye. She actually has a trail of exudates moving inferiorly, affecting the central macula as well. And we also took an OCT angiography at this visit. Now, it was interesting to go back through this case because this must have been one of the first patients we imaged at SUNY with an OCTA, because it was right around the time where we actually obtained the ability to do this testing. And at the time, we didn't know so much what we were looking at, and it's just amazing to think about how much more we've learned about this technology over the years. So what I've pulled here is her superficial capillary plexus at the top of the slide and the deep capillary plexus at the bottom of the slide. Of note, we actually can see that large retinal hemorrhage with the shadow here and that area of exudation inferiorly. What I'd like to focus on is the foveal avascular zone. And as we can see in the left eye, it looks a little bit smaller than it does in the right eye. And in both, it's actually a bit enlarged. And this we know is a hallmark of diabetic retinopathy. We get an enlargement of the foveal avascular zone. And this is seen more significantly in the patient's left eye.
These are beautiful images, Sarah. And I want to point out, if you're dealing with like inner retinal disease, like diabetic retinopathy, vein occlusions, you want to focus on those superficial and deep capillary plexus preset and FOS displays, exactly like you've put forth here for us. So thank you.
Absolutely.
Sarah, quick question. Are you routinely getting OCTs, OCTA, but also just regular OCTs on your mild NPDR patients and moderate ones, or are you sort of waiting till, they become more severe in retinopathy?
So years ago, I kind of was waiting. I didn't always think it was necessary if I wasn't seeing much retinopathy, especially in the area of the macula, to obtain these images. But now that we have the ability to do OCTA, even if there aren't hemorrhages or exudates present centrally, I really like to get a regular OCTA and then specifically, or a regular OCT and specifically an OCTA to look for this area of ischemia.
Yeah, I completely agree. And that's exactly what I do too. Even if they're early NPDR, I think your pictures here, this OCTA of the left eye really highlights why it's important to get that. So I'll let you continue, but I'm on the same page here.
Thank you. Okay, so we diagnosed this patient at this time with moderate non-proliferative diabetic retinopathy in both eyes and macular edema present in the right eye. And we now know that she had this significant area of macular ischemia more evident in the left eye compared to the right eye. So our plan at this time was to, of course, educate our patient on the importance of improved control and also refer to a retinal specialist to evaluate that macular edema for possible treatment. Despite the fact that she was 20/20, it was central, and consider a fluorescein angiography due to that documented ischemia in her retina. So unfortunately, this patient was lost to follow-up. We did see her finally 3 years later. At this time, she was 64 years old. She presented still with her diabetic history, except this time the picture looked a little bit different. So her A1C was 12. Her fasting blood sugar was consistently elevated. She was on a third medication, and she knew that she was not well controlled at the time. This was at the height of the pandemic in New York City. She was working from home. She was not exercising. She was not eating healthy. And she was aware that she had kind of let things slip. So she came in for an eye exam. So again, we have our color photos here. And you guys can see that this case has kind of escalated from a routine case to now an extreme presentation because she has proliferative disease. So if we look at the right eye, she has an area of pretty significant neovascularization of the right nerve. And if we look at the left eye, she has a very large area of neovascularization of her retina here. And of course, we see more hemorrhages and exudation as well. Again, we have those red-free photos, which tell the same story, but just give you a little bit of a different perspective and maybe highlight those areas a little bit better. And we have a close-up picture of the nerve. And you can see here just how many neovascular blood vessels are present over that right disc. So we repeated her OCT at the same visit, and luckily it seemed that that edema that was present 3 years ago since resolved, and for the patient, she did not have any history of reduced vision in that right eye or either eye over the last few years, but her OCT angiography will tell a different story, because we actually see an enlargement of the foveal avascular zone compared to her original exam. I do have a side-by-side comparison in a few slides, but for now, this is all from that visit. And again, we have those superficial layers on the top, the deep layers on the bottom. And you guys can see now that just overall, it looks darker, it looks less saturated with capillaries, and there's more areas of capillary dropout, both within the fovea and paramacularly as well.
It's sad, Sarah, we see a lot of these cases where because of the pandemic and because of all the same things you alluded to, now we see this extreme pathology that without the pandemic, we would have caught this, she would have had a 3-month follow-up and she would have started treatment sooner and she wouldn't have this sort of late stage diabetic retinopathy. And it's kind of sad, and it's sort of an overlooked problem that the pandemic sort of caused. Are you seeing a lot of these type of patients that have sort of been lost to follow-up and now are presenting with just tons of pathology?
Unfortunately, I have, especially being in New York. I think so many patients were so hesitant to come in during the height. And then, even still, I get patients that are really hesitant to ride the subway, go on public transportation. And unfortunately, I've had to deliver more bad news during and post-pandemic than I was pre-pandemic. And it's just so sad, especially in conditions where the acuity remains 20/20, but the patient is unaware about what's going on. You can't even fault them for wanting to stay healthy. But unfortunately, these things go undetected and untreated.
Good point.
Yeah, we've also seen a lot of cases in our clinic of like bilateral vitreous hemorrhages, tractional retinal detachments after the pandemic finally lifted and we were able to see these patients again. I agree. I think this is a great case because she still is 20/20. So this is an opportunity for you to get in there and intervene, and you're able to keep her good vision versus somebody who comes with like a MAC off tractional retinal detachment. It's hard to get that vision back.
Absolutely. At least we caught it in this case before that happened. So I'll move on to the next angiography slide. So anytime I'm suspicious for neovascularization of the disc or I see it in my clinical exam, I always obtain an angiography over the nerve as well. And I have that listed for you guys here. Just a quick note of the left nerve. This is a little bit of a segmentation error here, so that's why it doesn't look completely round. But in this particular slice of the OCTA, you want the nerve to look black. You don't want to see any blood vessels on top of the nerve here. And the right nerve, you can just really see how many blood vessels are there and how significant that neovascularization is. If you look at the bottom of the slide, we have our tomograms, and this indicates areas of red, which indicate areas of blood flow. So remember, our OCTA is taking multiple B scans over and over again and looking for movement in the retina, and that movement is going to be blood flow. So you can even see within this neovascular net, over top of the optic nerve, she has blood flow. So this is just a great image of what's going on both on FOS and a tomogram through that area of proliferation.
I think even without OCT angiography, let's say you're in a practice that you don't have it, if you're doing just structural raster scans through the optic nerve, you have that classic presentation of neovascularization on the disc, where I like to call it like a hammock hanging across the cup or that pre-retinal tissue. Because sometimes in patients that have, bad cataracts or poor fixation, nystagmus, I'll just kind of use a raster scan to like look around the posterior pole or kind of scan across the nerve, looking for areas of tissue sticking up out of the retina that may signify pre-retinal neovascularization, or as in your case here, neovascularization of the disc.
Absolutely. And that's a great point because not everybody has OCTA capabilities now, but if you have OCT capabilities, you can still use those tools to pick up that neovascularization. So in this patient, unfortunately, the OCTA did not capture that area of retinal neovascularization, but I did pull an image just to show you guys what that would look like. So this is showing that area, an area of retinal neovascularization. And just as was just said, we know that this blood vessel should not be growing on top of the retina. So you don't even need it to say that there's blood flow in the area. If you see a vessel that looks anomalous and you do an OCT through the area, you can really document that neovascularization quite well.
Dr. Parikh, I'm curious to have your input on that. Is it unusual to see patients that have neovascularization within that macular scan? I feel like a lot of the patients I'm seeing who are type 2 diabetics, a lot of the neovascularization is kind of like in the arcades or like out towards the mid periphery. What's your experience?
Yeah, absolutely. And a lot of it just, there's you're going to get a lot of variation in people's presentation, but I definitely agree with you. I mean, a lot of the neovascularization you're going to see is going to be in areas sort of in between ischemic retina and vascularized retina. So it'll be in the arcades and the periphery. And oftentimes you'll see NVD first and, or at the same time. But, there can be various presentations, and I bet there's in that patient in their left eye, I bet there's neovascularization elsewhere. If we look farther in the periphery, I bet there's other areas also involved. But yeah, I also did think that was interesting.
That's a great point.
The other one thing I did want to mention is, as we all know, these eyes, this is at such high risk given the level of pathology that these eyes can go south really quickly. I know, this patient's 20/20 right now, but, and I'm glad she finally got in and saw you, Dr. Gleason, because like, this is the type of thing where like, if she had gone another 6 months, who knows, she may have come in with that MAC off TRD, so I think it's key just getting her in.
Okay, so our plan for this patient. So she was diagnosed with proliferative diabetic retinopathy in both eyes. And of course, we have that area of macular ischemia more significant in the left eye. Our plan was to refer to our retinal specialist for treatment, and he opted to perform PRP in both eyes for this patient. So just an overview of diabetic retinopathy. We know this is something that we see all the time in the clinic, but it's always nice to just take a step back and remember what's going on in the retina in our patients. So we have our non-proliferative disease, and this is characterized by increased vascular permeability. In more mild stages, we'll see microaneurysms. As the disease progresses, we'll see more hemorrhages and exudates. And as severity increases further, we'll see cotton wool spots, ERMA, venous beading. In proliferative disease, we have persistent retinal ischemia, which leads to release of VEGF, which leads to angiogenesis. And this leads to development of NVD and NVE, as we saw in the case. Complications of this can include vitreous hemorrhage, tractional retinal detachments, all the things we want to prevent in our patients. Of course, we have diabetic macular edema. We're very familiar with this as it's the most common cause for reduced acuity in our patient. But in this case, we have a breakdown of the blood-retinal barrier, and this leads to intraretinal accumulation of fluid. In our patient, this didn't end up being something so significant that we were dealing with, but we see this very frequently. And we also have diabetic macular ischemia. So this is something that we don't think about or talk about anywhere near as frequently. However, it's something that's occurring in our patients, and we know that the retina is ischemic. That's why we worry about proliferation. And this is characterized by capillary occlusion and atrophy. However, you will not document this in your patients if you're not performing angiography. So previously, we weren't going to refer our mild patients to get a fluorescein angiography since it's a quite invasive procedure if it wasn't really indicated. However, with the advent of OCTA, we can actually document this on our patients very early on in the disease process. So again, I pulled up the patient's left eye, the areas of macular ischemia compared between that visit 3 years prior and the visit 3 years later. So if you guys can notice, she has a just overall reduction in capillaries. It looks just a little bit dimmer, a little bit less saturated on the right side of the slide. And you can appreciate how the foveal avascular zone is widened, and she has these areas paramacularly of that capillary dropout documented. So diabetic macular ischemia, we know that this occurs when there's capillary occlusion and atrophy. And as with our patient, visual function generally is not affected unless the ischemia is very, very severe. We do know that there is a correlation of severity of ischemia with the severity of the retinopathy, and therefore it can be an indicator of a risk of progression to proliferative disease. So there's many studies on this topic. I just pulled one that was published by Sheng Yu et al. In 2020, and this just confirms all of those things. So we know that if there's macular ischemia present, the patient may be more likely to progress to proliferative disease, and that we should consider earlier referral and more frequent follow-up schedule. And this is a figure from that study. The areas of blue are showing areas of capillary dropout, and you guys can see that that capillary dropout significantly increases with the severity of the disease.
Yeah, I feel like figures just like this have been published like over and over and over and over. Yeah, so I think this is a really well-known, well-established fact right now that the retinal ischemia increases with the severity of the disease.
Absolutely. So just some clinical pearls to wrap up this case. I always like to think at the end of every conclusion of every case is what is our goal of doing these clinical exams? And it's really to preserve vision. So every time we're examining our diabetic patients, we're trying to determine what is the risk of vision loss in this patient's lifetime. When do we need to see the patient back to ensure that we catch it if there is going to be vision loss, and when is treatment indicated? We now know, as we just went over, that diabetic macular ischemia is something that we should be looking for. If you have the ability to run OCTA on your diabetic patients, I recommend running it on all of them, regardless of level of retinopathy, because we know that it can be useful in determining how frequently you want to see that patient back, and it will help us better take care of our patients and hopefully better preserve vision for all of these patients that we see. And I think that's it. Do you guys have anything else to add about the case or the topic?
I thought that was fantastic, and I think your conclusion was great. And I just want to point off that one of the things you mentioned, where the patient doesn't really appreciate a decrease in vision until there's severe ischemia. And I just want to highlight that because, the whole point of getting this testing is to sort of twofold. One, it allows us to prognosticate, like you mentioned, Dr. Gleason, and prognosticate and see who we need to really follow closely. But I think secondly, if we can show these images to patients and they can see it with us, and we can just say, hey, this was your foveal avascular zone prior. Look at it now. This is getting worse. I know you're not symptomatic from this, but if it gets even bigger, then we're going to have a problem that's really irreversible. And so I think, even for education purposes, for patient education, I think this is I think OCTA is a really useful tool here.
I couldn't agree more. I was actually going to mention the same thing. I think especially when you have a patient who still has 20/20 vision, I was going to ask you, Sarah, was it hard to convince this patient that they needed to go see retina? Or were they kind of like in denial that anything was going on with their eyes? And the images really help, I think, convince them, right?
Yeah, the images helped a lot in this case. I mean, there was something to be said, the fact that she came in during the height of the pandemic when we weren't even doing regular patient care because she was concerned. So it was helpful that she was kind of, aware of her diagnosis and aware that things could turn south. But being able to turn that computer screen around, show her the photos of the neovascularization, show her the change from the visit 3 years ago, and talk to her about what her risks were if we did not treat it. She luckily was very amenable to treatment and was much more compliant moving forward. All right, so I guess that wraps up my discussion on OCTA and diabetic retinopathy, and we will now move on to the next case discussion.
Okay, so we're going to switch gears now and move from diabetic retinopathy to macular degeneration. And I'm going to present two cases. We're going to start with a more routine case. So this was a 60-year-old American Indian female. She came in just for a AMD follow-up. She had no vision complaints, hadn't noticed any changes on Amsler in her vision. She had been diagnosed with macular degeneration dry form 2 years ago, was taking AREDs only, hadn't had any other sort of ocular treatment like anti-VEGF. Her medical history, some prediabetes, high cholesterol. She was a former smoker. We know it's a risk factor for macular degeneration. And her best corrected visual acuities at this baseline visit was 20/25 minus in the right eye and slightly reduced 20/30 -1 in the left. And here we're looking at her color fundus photographs magnified on the macular region. And what I want to point out is that both eyes have these large sized soft drusen. And large meaning greater than 125 microns. And you're like, well, I'm going to whoop out my measuring stick and see if that's 125 degrees. Just look at the width of a vein as it crosses the disc margin, and that's 125 microns, right? So this is much larger than that. So this is a large size drusen. You only need one large size drusen in order to put you into the intermediate stage of a non-exudative macular degeneration. So that's clearly what she has in both eyes, assuming no neovascularization is present. So the drusen centrally are usually, or we think are probably soft drusen because they have these indistinct borders. But then there's another subtype of drusen that we can see in this patient's color fundus photographs, which are these small, discrete kind of focal deposits in the perimacular region. And Dr. Parikh, would you mind commenting on what you think this other variant of drusen might be, and what is the clinical significance of that for you?
Yeah, no, excellent question. And as you sort of alluded to, they're very different in appearance, and they we'll use some other imaging modalities, of course, in OCT and maybe in autofluorescence, and we'll sort of use that to help differentiate drusen, especially depending on what layer they're in. So these to me look like they could be, subretinal drusenoid deposits, also known as reticular drusen or pseudodrusen, and they tend to have a pretty poorer prognosis. I mean, as do soft drusen, So I'm looking at this, Carolyn, and I'm not, this is sort of like, I'm not too happy about this. And, one of the interesting things you mentioned that I wanted to point out was, on your first slide, I think you said dry AMD, diagnosed with AMD 2 years ago. And, I see patients like this all the time, and it'll be like, oh, I just got diagnosed with AMD last week. And, the first thing I think is, listen, you've had AMD probably for years,
Yeah.
You probably had early, it doesn't just become intermediate all of a sudden. So anyway, I'll let you continue, but, I see this and I'm like, she's had AMD for years.
I couldn't agree more. I think that's an excellent point. I appreciate your insights there. And then I want to look at her raster OCT scans. And this is a raster in each eye, the right eye and the left eye, through the center of the macula. So we're seeing these soft drusen as large, round elevations of the RPE. But I also want to point out that other subvariant of drusen that we were seeing, which are subretinal drusenoid deposits. And I think a really good example is nasal here in the left eye, where we have this nodular hyperreflective deposit that's anterior to the RPE. So it's sitting on top of the RPE in the subretinal space. And of note, there's no signs of neovascularization or exudation here. And what would you be looking for, like fundus exam or OCT wise, that should scream at you exudation, Dr. Gleason, do you think?
Absolutely. So you want to be looking for any breaks in Bruch's membrane, any areas where neovascularization might be growing and kind of presenting itself through the retina, and any indication that there is subretinal fluid present, which may be a little bit difficult to tell if there's a lot of drusen kind of overlying those areas, kind of covering up the subretinal fluid. So that's where OCT is going to be very, very helpful in these cases.
Couldn't agree more. Yeah, looking for the drusen, the hemorrhage, exudate, pigment epithelial detachment, I think is all really important. So I've already alluded to the fact that, OCT we can use to classify different various subtypes of drusen, like hard, soft, or these reticular pseudodrusen or subretinal drusenoid deposits. And what I want to point out is that there's some research that suggests that subretinal drusenoid deposits are high-risk biomarkers for progression, as Dr. Parikh had already pointed out, not only for neovascular conversion, but also for conversion to atrophic advanced AMD, which is like central geographic atrophy. And this is just one study that showed that if you have a combination of soft drusen, which we typically think of as high risk, with these subretinal drusenoid deposits, that puts you at an even higher risk than if you had just soft drusen alone. So she's at one of the highest risks for conversion to neovascular AMD that we could possibly have based on the drusen subtypes present. I want to now fast forward. I'm so sorry, go ahead.
No, just one quick thing. While we're on the topic of the subretinal drusenoid deposits, I just wanted to highlight some interesting research that was presented at the ASRS, the American Society of Retina Specialists meeting just about a month ago on subretinal drusenoid deposits. And the team with Theodore Smith at Mount Sinai found a link between subretinal drusenoid deposits and cardiovascular disease that was pretty substantial. So they postulate that there may be a link between cardiovascular disease and the presence of subretinal drusenoid deposits, and sort of a very interesting area of research. And I know you're interested in the systemic diseases, and yes. I think this is a very important topic.
I love that you bring that up. I mean, I'm a firm believer that AMD is truly like a systemic disease. So I think that's an excellent point.
I agree.
If we fast forward now back to our patient 4 years into the future, we see that we've had drusen regression in both eyes. So the right eye, we have a little bit more pigmentary changes, which are another high risk biomarker for progression to advanced AMD. And the left eye looked like most of that drusen has gone away. And I think, back when I first had graduated or finished residency, I probably would have looked at it and said, oh, your AMD is improving, how wonderful. But then the more I, looked into this topic, drusen regression is actually a risk factor for progression to advanced AMD, especially the atrophic geographic atrophy form. And as we're seeing on her OCTs, that kind of helps confirm what's going on. In the left eye here at baseline, we had these large confluent soft drusen. At the 4-year follow-up, those drusen have collapsed, and we're starting to form what we call nascent geographic atrophy. And I like to think of this as like impending geographic atrophy, where we have a hypertransmission choroidal signal due to attenuation or loss of the RPE. And the outer plexiform layer seems to just be like sinking or kind of falling down into that pit. We know that this lesion is probably going to go on to develop full-blown geographic atrophy with complete atrophy of the photoreceptors and RPE. Some other high-risk biomarkers on OCT I want to point out that have formed in the right eye over the past 4 years. These hyperreflective foci, which are like these little hyperreflective deposits that often are on top of the apex of drusen, are also high risk for conversion to advanced AMD, as well as these hyperreflective columns, which are like these vertical bars of hypertransmission, telling you that the RPE on the apex of this drusen is compromised. So oh, go ahead, I'm sorry.
I just wanted to ask you, when you're seeing these signs that indicate that it's a poor prognosis for your patient. How do you have these conversations with your patient? Because unlike a lot of the diseases that we manage, there's not a lot that we can do for our patients kind of earlier on in this disease phase other than watch them until they get worse. So how do you kind of navigate those conversations?
I think that's a great point. I mean, for me, usually patients at this stage aren't really symptomatic. So I always seem more concerned than they are, because I'm like, oh my gosh, I think you're going to convert. I need to watch you really closely, like every 3 months. And they're like, I'm not really having any vision problems, but okay. So I think having that education about AREDS2, if they're not already taking, I would definitely recommend it at this point. Although I think there's little support to say it decreases the conversion to GA versus neovascular AMD. But then also just having an in-depth discussion, stop smoking, UV protection, nutritional, like dietary modification is really important, I think, because we have nothing else that we can do right at this time, at least. Coming down the line, hopefully.
Absolutely.
And that conversation is going to continue in our later panel discussion.
Yeah, looking forward to that. So I want to point out that OCT angiography is really valuable in detecting early neovascularization, because it's going to allow you to directly visualize the membrane itself, not just the secondary exudative effects like fluid or whatever, actually looking at the membrane. So anytime I have a patient, like let's say this patient's right eye, where there's a large drusenoid, presumably drusenoid, pigment epithelial detachment, I'm going to position my segmentation lines on OCT angiography. So I'm sandwiching that PED. I want to see what's inside that PED sandwich. And is there neovascularization in there, right? So if I'm looking at my INFOS image, neovascularization looks like a well-formed vascular net. I'm going to show you here in a minute. This patient just has atrophy of the choriocapillaries, which is a characteristic feature of atrophic macular degeneration. And just to put that in context and contrast it with the pigment epithelial detachment here that is vascularized. So there's a shallow, irregular pigment epithelial detachment. And on OCT angiography, we see this well-formed neovascular net, right? A very different presentation than this patient where it's truly drusenoid avascular versus this is a vascularized PED, definitely something I'm going to refer to retina and get a second opinion on. This patient may benefit from anti-VEGF therapy. Let's now fast forward in time, one more time, at 5.5 years of follow-up. In the right eye, there's even more drusen regression, and we're starting to see multifocal geographic atrophy forming in the right eye, even centrally there. And then in the left eye, we have sort of frank geographic atrophy has formed centrally there, about 1/3 disc area in size. It seems bigger than previously. And on OCT, again, we have almost complete drusen regression in the central fovea of the right eye. And we now have nascent, impending geographic atrophy lesions where the retina is sinking down towards these areas of RPE atrophy with choroidal transmission defects as well. And then the left eye, this area of geographic atrophy seems to have enlarged compared to just 1 year ago. Fundus autofluorescence, I think, has a lot of value for 2 reasons in this case. One is looking at reticular pseudodrusen, which can be hard to see with just color fundus photography alone. And they look like dark hypoautofluorescent deposits on fundus autofluorescence, this kind of reticular pattern, really classic presentation of pseudodrusen. But then it also helps you delineate and monitor over time areas of geographic atrophy. When you have atrophy of the RPE, that's going to appear dark or hypoautofluorescent on FAF imaging. So we know that geographic atrophy is irreversible, unfortunately, and foveal involvement can actually occur probably faster than most of us think. When you think about geographic atrophy, at least me, you're like, oh, there's nothing to really do. It's like slowly progressing. But the fact of the matter is that it can be like 2.5 years from extrafoveal GA to when it actually involves the center of the fovea. Fortunately, there is hope on the horizon for these patients with geographic atrophy and nascent geographic atrophy. There are several pharma companies working mostly on complement inhibitors. Most of them are intravitreal injections. They're looking at an oral one I've also listed here that's under investigation. So there's really an exciting future, I think, to come for the treatment of geographic atrophy. And we need to prime ourselves now, because I think the first drug is going to hit the market at least in the US, that is, those of you who are attending or in the US, probably by the end of this year. And so we're going to identify these patients, start rounding them out now that have geographic atrophy, especially extrafoveal GA, that may benefit from slowing the progression and helping to stabilize vision. Let's now switch gears and talk about the more extreme end and visually devastating, form of AMD, which is neovascular AMD. While only about 1/5 of AMD cases are exudative, neovascularization accounts for 90%, the majority of severe central vision loss from macular degeneration. So early detection by optometry, by anyone, is really important by the patient. If they can recognize the symptoms or on Amsler grid home screening, whatever that may be, early detection is crucial. So you need to be looking on fundus examination for hemorrhage, for exudate, for the grayish green subretinal thickening. Right, on OCT, you want to be looking for fluid, pigment epithelial detachment, especially if it's an irregular contour. It has a weird internal reflectivity. Or on OCT angiography, if you're seeing a frank choroidal neovascular membrane, that should all be concerning to you and you need to refer that out. The early retreat, the better the visual outcomes. I know, Sarah, you presented a case that kind of fell by the wayside because of COVID. I'm going to do a similar thing. So this was a 73-year-old American Indian female. She complained of decreased vision in the right eye for the past 6 months. She had a history of dry macular degeneration that we were following her for several years. She kind of missed 2 appointments, went off the wayside for about 15 months and just showed up as a walk-in kind of in our emergency clinic. Her vision at this point was 2100. We had previously had her documented as 2020. So if we look at her color fundus photograph, we have this classic like grayish green subretinal thickening with an adjacent subretinal hemorrhage and retinal exudate, all features of exudative AMD. And then I'm going to show you several different raster scans, just structural OCT raster scans through her macula. So here in the center area of the macula, we have fluid at pretty much all levels possible. We have intraretinal fluid, we have subretinal fluid, and then we have this kind of irregular contour, multi-lobed pigment epithelial detachment that seems like it probably contains mostly fluid. Also want to point out this subretinal hyperreflective mass, which is the membrane itself that we're going to be able to visualize with OCT angiography here in a second. And look at this subretinal hyperreflective mass in the inferior macula. Again, this is the membrane itself exuding subretinal and intraretinal under the RPE fluid. Here on OCT angiography, this is the in-FOS image, and this is a 6 millimeter scan. So you can imagine how huge this choroidal neovascular membrane is. It's very mature. It has these like large feeder vessels associated with it. And then this is our B-scan overlay. So as Sarah mentioned earlier, the red aspect on top represents blood flow on top of your traditional structural OCT scans. So remember that hyperreflective mass that we had with the structural imaging, it highlights in red, and that's the area of neovascularization that's kind of sandwiched between the RPE and the retina. And then these large feeder vessels here, we can see the lumens of those actually sitting in the subretinal space here.
Carolyn,
But I think maybe that's something we can talk about in the panel discussion later with regards to like what changes would you expect in the OCT angiography morphology pattern with successful anti-VEGF treatment.
Carolyn, I was just going to say those last 2 slides, the images were amazing, where you can actually see that flow in the choroidal neovascular membrane. I think you look at a slide like this, and this sort of clinches your diagnosis. If this isn't one where you're like, oh, is this exudative? Is it not? You see this, and this is like, okay, you need treatment. So this is a beautiful slide.
I appreciate that. And for me, when I see like an eye here that's like so far gone, my immediate focus is to say, okay, even with treatment, this isn't going to change. I got to immediately change my focus to the fellow eye, do OCT angiography on that, a ton, make sure I can pick up the earliest neo possible in basically now what is a monocular patient.
Agreed. And the earlier you treat, the better. So picking it up early on in the fellow eye is of utmost importance. I will say I have had some success in treating these patients, even when they come in as far gone as this. You reduce that fluid, and it's never going to take one injection. It's going to take multiple injections, and the patient has to sort of, they sort of understand that, and when it gets to this point, and like you said, does the vision ever, is it going to be 2020 like she was before? No, but sometimes what you can do is you can really decrease the fluid. You can regress a little bit of that membrane, and even their central scotoma can get a little smaller. I still treat these aggressively with anti-VEGF, and you do get some success, but like you're saying, this never goes back to like, a perfect eye, at least right now.
Yeah, I appreciate that insight. Yeah, I think she was 2100. What do you think if she had been complied with anti-VEGF treatment, which unfortunately she wasn't, where do you think she could have gotten to vision wise?
Yeah, it all depends on how early they're in, and then how good they are with the treatment in terms of follow-up. And also it depends how well they respond. It's interesting. We don't completely understand, but some patients respond a lot better than other patients to anti-VEGF. And then in some we're changing the anti-VEGF and we're decreasing the frequency of injections. But yeah, there's people that respond beautifully, and there's people that don't respond as well. And I think we still have to figure out why that's the case. Yeah.
Hopefully some longitudinal OCT angiography studies will identify like OCT angiography patterns that are going to respond best to even perhaps certain medication. So in just the take-home summary of these two cases we presented, really important that you recognize OCT biomarkers that are high risk and predisposed to conversion from the intermediate non-exudative stage to advanced advanced AMD, whether that's central GA or neovascular AMD. Begin rounding up and looking for these patients with nascent, especially extrafoveal geographic atrophy that are going to be amenable to treatment that's coming out later this year, most likely. And then know the features of exudative AMD, literally like the back of your hand. You've got to recognize them. You've got to pick it up super early so that you can refer for immediate anti-VEGF therapy. And often OCT angiography really facilitates the earliest diagnosis of exudative or neovascular AMD possible. Any closing thoughts, guys?
Just wanted to comment on how fantastic your images are. It's a really great tool for you to manage these patients. And as we discussed with the previous case, to help educate your patients as well, if not to get treatment of the current eye you're imaging, but to hopefully monitor more frequently and be better compliant with their follow-up visits, their home monitoring of their vision, so you can preserve all vision possible in all of these patients.
Thank you.
Sarah and Caroline, those were, both of you did an amazing job. Those are amazing cases, and it really highlights the spectrum of pathology that we can see in dealing with these retinal conditions. So thank you both. This was fantastic. Hi, good evening, everyone. Thanks again for joining us tonight for our live panel discussion. I'm here with Dr. Sarah Gleason and Dr. Carolyn Major. And just want to start off by saying those cases were excellent, phenomenal cases. And we have an interesting discussion here for you tonight. It's meant to be interactive, so we've already started getting some questions, and we'll try to get to all the audience's questions. And we have a couple of polls that you're going to see on your screen momentarily that we're going to get to as well. I wanted to start off the discussion by starting with diabetic retinopathy and moving over to macular degeneration. So, just wanted to start with normal again, and keeping with our theme. So we start off with mild and moderate NPDRs. And Dr. Gleason and Dr. Major, I'll turn it over to you. But how frequently are you seeing your patients with mild to moderate NPDR? And we had some great OCTA images. How frequently are you imaging them? Either with OCT or with OCTA? And I'll start with Dr. Gleason.
All right. Yeah. So for my mild patients, I'm generally seeing them from anywhere from 6 months to a year. Normally, I'll follow them yearly, but there will be some instances where I want to see them just a bit more frequently, and then I'll push them onto more of a 6-month schedule. And the same kind of thought process goes with my moderate patients. So if it's moderate, but just barely moderate, I might say 6 months is okay. But if they're developing more areas of ischemia, I'm definitely going to follow them more closely. So more often I'm seeing these patients every 3 to 4 months. And a lot of what's driving my decisions in terms of the follow-up care isn't so much just that overall stage that they have, but it's really what I'm seeing on their imaging. So we all know that we can have a wide range of mild and a wide range of moderate. And based on additional imaging techniques that we have more recently, like OCTA, we can have more insights about those areas of ischemia. Those patients with more ischemia, of course, are more at risk to develop proliferative disease. So the more we kind of learn about these diseases, the more we're able to image these diseases, the more I'm actually catering my follow-up schedule specific to each case rather than having a catch-all for each stage of the disease.
Yeah, and for mild NPDR, I'm usually monitoring every 9 to 12 months. Moderate is usually like 6 to 9 months, again, depending on how many risk factors are present. Regarding imaging, I think for moderate NPDR, I'm probably doing like a MAC OCT yearly. I think imaging really helps come into play for more severe stages of the disease, like severe NPDR versus early PDR.
Yeah, I completely, agree with your sort of follow-up timeframes. The only caveat I'll add is, I'll often ask patients what their A1C is, as we all sort of do, and just get a sense of their overall, how they're doing systemically. And, I'll get these moderate NPDR patients that are like A1C of 12. And, I'm going to treat those a little bit differently than my regular, moderate NPDR, A1C of 6.8, recently diagnosed with diabetes. And I take that into account too. Sometimes when I look at these patients, Carolyn, Sarah had a good photo of of NVE that was caught with OCTA, and I know you have some great cases. Can you share some of those photos with us of catching early NVE or even late NVE with OCTA imaging?
Yeah, I would love to, and I think one of the best ways to do that is using montage OCT angiography imaging. I mean, that's a really exciting development that has come out, in just the past few years on most OCT angiography machines. And montage imaging is going to allow for extended field of view and imaging of the vasculature outside of the arcades in patients with diabetic retinopathy. And because OCT angiography provides high resolution microvascular detail, it's going to help us visualize these small microvascular pathologies that we might not be able to see with fundus examination, like mid-peripheral non-perfusion, small areas of neovascularization, like you had mentioned before. So it's going to help you more accurately stage the disease. And the volumetric data set of information, vascular information that we get from OCT angiography, we can segment out. We can also segment that out with OCT angiography montage. And so the vitreoretinal interface is one of the best presets to look for pre-retinal neovascularization. And I also want to point out, look for pre-retinal neovascularization on the border of perfused and non-perfused retina. And OCT angiography montage makes it really easy to identify that border and inspect along it. So the vitreoretinal interface, that preset NFOS display, is showing us any vascular data anterior to the internal limiting membrane, where pre-retinal neo usually grows, right, is on the posterior hyaloid. So look at the vitreoretinal interface to identify those early cases of proliferative diabetic retinopathy that probably deserve PRP and need to be referred out.
Excellent, excellent. And I want to take this time now to start shifting gears a little bit. I will make one comment here before we move on. I love how on the OCTA, and again, Carolyn, me and Sarah are a little jealous of these images, and that's why we really wanted you to share these with everyone. I mean, look at that capillary non-perfusion, right? Look at that capillary non-perfusion and that neovascularization. This should be in a textbook. This is like, these photos are amazing. I still do a lot of fluorescein angiography for patients, and really, I'm starting to think about doing more OCTA montages based on this. I think this is fantastic. With the exception being, if you're looking for something like vasculitis, that you're not going to be able to pick up on the OCTA. So, that you'll still go to your tried and true fluorescein angiogram. In shifting gears, I'm going to start with the first poll question here. And now we're shifting into macular degeneration a little bit. Upon observation of drusenoid regression, by the way, Sarah, Carolyn, you're gonna scare everyone with this slide. Maybe go back one.
All right.
Upon observation of drusenoid regression, how would you change your management? So most people said upon drusenoid regression, they would monitor more often. That's 38% of people. 35% of participants said they would order an OCTA scan, and only 23% said they would just continue management as planned. Sarah, what do you think of that? Where would you fall into this poll?
I actually love the split that we see between those first two answer options, because I kind of want to do both for this kind of case. So I would change my management to a little bit more frequent visits, but I also am going to make sure if I wasn't already getting an OCTA scan on the patient, I would want to do that too. So I'm going to pick 2 for this one.
Agree with you 100%.
And then our next poll question is, which of the following patients would most benefit from an OCTA scan? So this is actually very interesting. So neovascular AMD, 49% of participants said they would most benefit. Intermediate dry AMD, 41%. And early dry AMD, 10% of doctors said early dry AMD, they would still get an OCTA scan. Carolyn, what do you think? Where would you fall into the spectrum?
Yeah, I think both neovascular AMD and intermediate dry AMD are very appropriate responses here. I'm probably going to go with intermediate dry AMD. The reason being is that I feel as like a primary eye care provider, it's my job to detect the earliest neovascular AMD, the early exudation and activity, and refer that out for prompt treatment. And I think monitoring those intermediate dry AMD patients with risk factors for progression to neovascular and exudative disease is absolutely critical with OCT and OCT angiography, looking for neovascularization.
Excellent, excellent. We're down to our last couple of minutes. I want to make sure we don't run over. We had a couple of good questions from the audience I just want to touch on. And then one of them being, are we seeing more vision loss due to eye pathology and disease because it's being missed, because a lot of people are turning to online glasses purchases and eyewear purchases and online vision, screening. So are we missing some disease, and is it presenting later, sort of like what's happening during the COVID pandemic? Are you guys seeing that?
Yeah, absolutely.
Oh, I'm sorry. I'll Dr. Gleason, if you want to go first, and then Dr. Major.
Yeah, I would just say absolutely. And it's unfortunate. And it's our goal to really educate our patients while they're in our chair, and using images such as these, I think, is just really the best way to get that point across.
Yeah, completely agree. I mean, I think it's even like patients that have LASIK, and then they, never come back for follow-ups, but they still have lattice and things that need to be monitored. It's patient education is absolutely critical, I think, for a lot of things that we do.
Excellent, excellent. We're down to, unfortunately, our last 30 seconds. We wanted to touch on these topics are there's so many patients that have retinal pathology, and the innovations in our field in optometry and ophthalmology are moving at such a fast pace that it's very exciting that we're able to have this conversation and share our time with you all. There's a lot more we want to talk about, but unfortunately we're not going to be able to. And at some point in the future, we'll discuss the million pathways of the complement system. But we're going to end here, and I just want to leave you with one takeaway. As our field is advancing, we really want to leave our patients with hope that there's a lot of treatments on the horizon, and if we can keep our patients from keeping hope, and we can continue to progress as a field, I think there will be a lot of benefit to a lot of patients down the line. So I want to thank everyone, for Dr. Gleason, Dr. Major, and of course, Eyes on Eye Care and Zeiss. And thank you everyone for a wonderful, wonderful night.